like whatever at every point, what all questions they may ask, try to guide as much as possible in that. Okay.
Sure,
So
sir. Sure.
start. We'll see. Okay. 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 Then.
Yeah. Thank you, sir. My patient is 60-year-old male, resident of Mahim, Mumbai, retired teacher by profession, admitted at the PD Hinduja Hospital on 10th of January 2025 and history taken on the 11th of January 2025. Informant being patient himself and her wife. Patient presented with complaint of palpitation since last 6 months, breathlessness since 3 months, and swelling over the both the leg over since last 15 days. Patient was apparently all right and performing his daily activity till 6 months ago, when he noticed his heart is running fast after doing day-to-day activity. Uh, Palpitation is insidious in onset, regular, daily, and increases with exertion and decreases with rest. It is not associated with any chest pain, breathlessness, syncope, post-palpitation diuresis. 3 months ago, patient started feeling breathlessness, which was insidious in onset. Patient initially had a breathlessness on the exertion after doing the daily activity or walking around 1 to 2 kilometer outside, which gradually progress on the walking even 50 meter at home since last 20 days. Breathlessness increases on the lying down in supine position. Patient had episode of awakening at midnight after 2 to 3 hours of sleep due to the feeling of the breathlessness, which was relieved by the sitting up and taking a deep breath for 10 to 20 minutes. First month, after the first month of this episode is gradually disappeared. Breathlessness is not associated with any cough with expectoration, wheezing, or there is no history of fever. Patient had a swelling over the bilateral dorsum of the feet since last 15 days. It is painless in nature and extended to the both the angle. There is no history of redness, early morning facial puffiness, frothy urine, jaundice, abdominal distension, hematemesis, or melena. There is no history of migratory joint pain, no history of angina or syncope, no history of nocturnal angina, no history of hemoptysis, no history of weakness of limb or the blurring of vision. Family history, no cardiac complaint in the family. Personal history, patient is taking mixed diet, appetite is reduced since last 2 to 3 months. Bowel and bladder habits are regular. Sleep is disturbed, no alcohol or smoking habits. The summary, sir. 60-year-old male patient with no comorbidity presented with insidious onset, regular palpitation since last 6 months, with progressive dyspnea from NYHA grade 1 to NYHA grade 4 associated with orthopnea and having bilateral lowering swelling, bilateral lowering pedal edema, no feature suggestive of endocarditis or rheumatic activity. So my probable diagnosis is query ischemic heart disease, uh, query valvular heart disease, and dilated cardiomyopathy.
Okay.
Yeah.
So, yeah, hi Dharman. So, Dharman, why do you think like patient initial symptoms was palpitations, no?
Yes, sir.
So, you have kept first diagnosis as ischemic heart disease.
Uh, yes, sir. Because the age of patient is age of the 60 year, and after ischemic heart disease, like a heart block or any supraventricular tachycardia can be occurred.
Hmm.
So just on the basis of
Yeah,
age, I
but
have kept it.
yeah, yeah. No, you can keep it in differential diagnosis. That's not an issue. But I don't think you should keep it as a first diagnosis because see,
Agreed.
I think so. Because there is no chest pain as such, no angina also, and
Yes, sir.
palpitations are first started, and then dyspnea, all these things has came up. So maybe based on his age, you can keep it as maybe third, fourth, somewhere around that. But I don't think first it should be there. Okay,
Yes, sir.
and other than that history, so you said this 60-year-old male, no, no medical comorbidity, started with palpitations. You said okay. So
Yes,
you
sir.
said palpitations were regular, insidious onset and regular, and it was exertional, na, basically, you were saying that.
Yes, sir.
So, okay. So how did you find out that the patient was having regular or irregular? So how did you ask him by history wise that it was regular palpitations or irregular palpitations?
So I asked the patient, how you feel that racing of the heart, and I Miss knock the table
Yes.
regularly, then otherwise irregularly. So he said the pattern was
Okay.
the regular like.
Okay. So basically, you demonstrated him and you ask him which type he get. So that's what you're saying right now.
Yes, sir.
Okay. So that's about palpitation. Yes. Okay. And breathlessness, you said first it was on exertion only, and later on it developed to orthopnea basically and PND
Yeah,
episodes. You're saying.
PNG now.
Okay.
Yes, sir.
So 3 months. All everything happened in 3 months only. No.
Yes, breathlessness over 3 months, sir.
Okay. And then pediledema happened. Okay. So now,
Yes, sir.
based on this, what do you think? The first diagnosis, what do you feel which disease it could be? See, dilated
This is
cardiomyopathy you said, but again, palpitations coming first, then breathlessness. It's unlikely. You can keep it as
unlikely.
still like third, fourth diagnosis maybe, but not the first diagnosis. So
My
whenever you're
first
giving
diagnosis.
differentials, na, you should
Yes,
always give the most like based on your history. What do you think most likely it could be, and then you give the remaining things. So based on okay. So there you can
yes,
modify a bit. Okay. Okay.
yes, sir.
So
So,
you
sir,
said
my
valvular
first
heart disease.
diagnosis will be
Uh,
valvular heart disease.
Which
Most likely
valve?
pressure overload like condition, sir.
Pressure overload. Okay.
Yes.
No, so pressure overload means you're saying stenotic lesions basically.
Sorry, sir. Volume overload, sir. Sorry.
Okay. So you said volume overload. Okay. So which one maybe? Which you're saying? Left sided or right sided you're saying?
More likely left-sided because patient is also having a feature of orthopnea and PND. So
Okay. So
left-sided,
in
I
which
will.
one in
Mitral
left side? My
regurgitation and aortic regurgitation. I will like to give a differential, sir.
okay. So based on history, which ones fits into that? Mitral or aortic? What do you think? So how do suppose what I'm asking is indirectly based on history, how you differentiate mitral regurgitation with aortic regurgitation specifically?
Um,
Is
uh,
there anything based on that which we can differentiate? MR or AR? One
Sir,
symptom which is more classic of AR.
nocturnal
Correct.
angina is typical of AR, but I did not
Correct. Correct.
find any history.
Okay. Okay. Good. Good. Yeah, that was certainly I'm asking. So generally, aortic regurgitation usually the patient will have nocturnal angina as such. Okay.
Yes,
So this was palpable. So you basically say it's a regurgitation lesion. That's what you're saying, right?
yes, sir.
Okay. Any other disease you think it could be? Like any other congenital heart disease which can present at this age, at the age of 60?
Aort, uh, atrial septal defect (ASD) can also present, but it will not. It will generally present as a right heart failure compared to left heart failure.
Yeah, correct. So it can present as palpitation. No, that can be a possibility.
Yes,
Dyspnea, yeah, may not be much, but swelling again can happen. Okay. No, still, but you need to keep that differential. No? So any valvular case, na, try to remember, like, no, not for in this case, generally in every case, na, so at each age group, what all congenital heart disease you can get, that you try to write a list somewhere. Like, mostly, don't go to very uncommon diseases. Most common diseases at what age do they usually present and all. So natural history of all the common congenital heart diseases and common valvular heart diseases should be known.
okay, sir.
Okay. So that is generally examiners are very fond of that. They keep asking you. So now you have
Okay,
mentioned everything. No? So it's because since he's 60, generally congenital heart diseases will be very rare. Usually, even if ASD also, usually starting presentation at 60, it will be very rare. Will not
yes, sir.
happen. So, so otherwise, I'm saying in any case, suppose you get a 30-year or 40-year-old male with similar symptoms, no, always try to remember at ASD presents at which age, natural history of ASD, VSD, PDA, TOF, coarctation of aorta, Epstein's anomaly. So all this congenital heart disease natural history you should be aware of.
Yes, sir.
Okay, and each age you can write it somewhere because while during exam, na, when you're presenting, na, you should not be thinking like it should be in your fingertips, like each year, which one you said, na. So based on 40 years, so I think this all can happen. So 60, this all can happen. All this should be in your mind.
Yes, sir.
Okay, so you can go through
Okay,
the books and all, and you can write it somewhere. All write it everything at one place, and that will be easy for you in exam.
okay, sir.
Okay, so you said MR and another thing while presenting history, na, don't try to mention in headings. You mentioned na, family history, personal history,
Uh-huh.
like that. So make it
Yes,
as a story itself. Like on exam, on families, you can ask like suppose you finish past history, na, there was no
yes,
similar history in any of the family members. You can go in that way rather than saying family heading of family history, then personal history. So
Okay.
many of the examiners will be very happy if you go in a story way rather than like heading wise. So no, so you can change that also in your
Yeah.
presentations also.
Yes, sir.
Okay. And when you present now, after 2 3 presentations, try to present. You are now reading na in the paper. It is there, I think. No.
Yes, sir. Yes, sir.
Okay. So after that, you practice that also without saying also, because
Okay, sir.
usually in DNB they may not give you the your case sheet. Sometimes few examiners take away your case sheet and you have to present it without saying also.
Oh, okay.
Okay. So practice that also. So
Okay, sir.
this sometimes happens because DNB frequently they do that. Okay, so you have to practice it before without seeing also. So because since maybe your first presentation here, wherever you present, na, after 4 5 presentation, try to do it without that also, like without seeing your notes also. Like
Okay, sir.
maybe you yourself can sit together. You maybe two people, na cardiology there, so 6 people around. So you can
Yes.
present yourself and practice that, and that will bring you more confidence. Because suddenly they said, no, you're not prepared. Na, suddenly they took case sheet, and in that tension you may miss many of the things. So you have to practice
Right.
it before. Yeah. So that's one thing. Okay. Okay. So you feel mitral regurgitation as thing. Okay. Can it be pulmonary hypertension, Dharmen?
Pulmonary hypertension can मतलब present as a exertion dyspnea, but orthopnea and PND is less common with pulmonary hypertension, sir. And there is no secondary history of asthma, COPD, or no any
Okay.
family history of pulmonary hypertension too.
Okay. Fine. Nice. Okay.
Okay.
So you can start with general examination and go a little slow, Dharmen, because we're not seeing your case now. So go a little
Oh,
slow. Okay.
yes, sir. Yes, sir.
Yeah, yeah. Start with your general examination.
Yeah. Examination. Patient is conscious, cooperative, oriented to time, place, and person. Lying at 45 degree in bed. Weight is 66 kg. Height is 164, and BMI is 24.5. Vitals. Pulse 78 per minute in right radial artery. Uh, it is rhythm. Regular in rhythm. High volume. Collapsing pulse. All peripheral pulse felt well, and no radio radial and no radio femoral delay. Blood pressure. Right upper limb 130 by 40 mm of Hg. Left upper limb 120 by 50 mm of Hg, and both lower limb systolic blood pressure is 210, sir. Respiratory rate 18 per minute and thoraco-abdominal type. SpO2 98% on the room air and 98.4-degree temperature. JVP is 5 centimeter from the sternal angle. Inspection and palpation. Should I go ahead, or should I
Yeah.
stop, sir?
Yeah, yeah,
Go
sure.
ahead.
This thing you're presenting JVP here only in general examination.
And with vitals, generally we mention, sir.
Oh. So
Uh,
there, okay. So no, like many of the cardiologists usually prefer that thing to be in cardiological examination itself rather than in. Okay.
okay,
There, how
sir.
do you say you presented to somebody there?
Sir,
Or they
Hegde sir,
only
we have
presented?
presented, and we have presented like same format in vitals. We say
Okay.
JVP generally.
Okay. Okay. Fine. So
Yeah.
no, okay. Yeah, no issues. Some usually many of them prefer to be in cardiological examination, JVP. So that's one thing. And
Okay.
you said BMI pulse sources. Okay. So collapsing pulses. How did you examine that collapsing pulse?
On the first, we encircle the our hand to fill the radial and the ulnar artery together, and the second hand at the where the radial pulse felt feeble. And after that, we abduct the arm over the shoulder, and we can feel the third over the hands.
Okay. Got it.
Okay.
Okay,
Should I
you can
go ahead?
continue. Continue. Yeah, go
Yes.
ahead, Dharman. I'll write. I'm writing down here. I'll ask you later only. Finish your
Okay.
examination. Okay.
Okay. Inspection and palpation. Apex impulse in sixth intercostal space, 3 centimeter lateral to mid-clavicular line. Hyperdynamic in nature. Parasternal heave absent. Palpable P2, palpable sound absent. Trachea is in center. No scar, sinus, uh, visible vein or any visible pulsation. And chest is bilateral symmetrical. Auscultation. On the mitral area, S1 is soft. On the apex, pansystolic grade 3 murmur, high pitch murmur radiate to the axilla, best heard with diaphragm in left lateral decubitus position with breath hold in the end of expiration. Tricuspid area, S1 is soft, grade 3 murmur, high pitch, pansystolic murmur radiating to the epigastric area, best heard with diaphragm of stethoscope and with breath held in the inspiration. Pulmonary area, grade 3, ejection systolic murmur, best heard with diaphragm uh, and in leaning forward position. Aortic area, grade 3, high pitch, soft blowing, early diastolic murmur, which is radiating to the carotid, best heard with stethoscope in sitting and leaning forward position with breath held in the expiration. In carotid, uh, the Corrigan sign was present. It was pulsatile. And impression, acquired valvular. My first differential will be acquired valvular disease, severe aortic regurgitation with severe mitral regurgitation with tricuspid regurgitation, probably rheumatic etiology in nature with NYHA grade 4 breathlessness, uh, and patient is in heart failure with pulmonary hypertension. Patient is not in atrial fibrillation, no sign of infective endocarditis or rheumatic fever or active rheumatic fever.
Okay. So this you mentioned pulmonary venous hypertension. You didn't mention diagnosis.
Yes, I mentioned actually.
Okay. So and only if arrhythmia is present, then only you mentioned atrial fibrillation. You shared na the no atrial fibrillation at present. You can either say just normal sinus at present. Maybe the rhythm is normal sinus rhythm.
Okay, sir.
Okay, so that is one thing. So how did you said whether did you mention that it is severe AR? How do you say that?
As the patient is having a left ventricular dysfunction feature with a feature of pulmonary hypertension and right-sided heart failure feature also. So on the basis of that, I said the patient is having severe AR.
Okay. Other than that, any specific thing? How do we actually say AR as severe?
On the basis of the Hill sign, we
Examination
can say
hills and okay. So how much it should be like? How much should be? Normally,
difference
can
between the
what the pulse pressure difference?
it present after 60 mm of Hg pulse pressure difference between upper limb and the lower limb, sir.
Okay. And MR, how did you say it is severe MR?
Sir, again, patient is having a pulmonary hypertension and a feature of the right-sided heart failure. On the basis of that, he said severe MR.
Okay. So that could be additional add points, no? But I don't think MR usually. How do we say that severity is not based on only on the pulmonary hypertension and right heart failure? No, other than that.
Uh, uh, Timing of the murmur, longer the time, I think
Okay.
more
So it's
severe is MR.
pancreatic. Okay. So which grade you said? You mentioned the grade of murmur. That MR. What grade you said that?
Grade 3, sir.
Grade 3. Okay. So how do you grade murmurs? Systolic murmurs.
Uh, Grade 1 is not audible but faint but not audible. Grade 2 faint and audible with effort. Grade 3 moderately loud. Grade 4 loud enough and the thrill is present. Grade 5 on the putting the stethoscope over the chest, loud murmur can be heard. And grade 6 by taking stethoscope slight centimeter away, we can heard loud sound.
Okay. And one more thing you said, no? You said total four murmurs, no? One was the early diastolic murmur at aortic area. One
Yeah,
was pansystolic murmur at that left fourth intercostal space, and one at apex. That's TR and MR murmur. One more murmur you mentioned, no? Then some
pulmonary
systolic
hypertension,
murmur.
sir.
Okay,
Ejection
ESM
system.
murmur mentioned.
Yeah.
Okay. You said click was this was there. Sorry, loud P2 was there. Huh? You mentioned that it was there or it was
Mm,
not there.
Sir, actually, I was not able to appreciate P2 and
Okay,
even split in this patient separately.
okay. But in diagnosis you mentioned, no? Severe pulmonary artery hypertension.
Yes, I have mentioned, sir, pulmonary hypertension.
Okay. Okay. So since now, so how did you decide it was severe PH then? Only on the basis of right ventricular failure, you said. How do you say that?
No, sir, I have just written pulmonary hypertension. Might be right ventricular failure is a feature of a severe pulmonary hypertension, but in severe pulmonary hypertension, there might be a right ventricular hypertrophy, which can perceive as a parasternal heave. But in this patient, I'm
Uh-huh.
not able to get any parasternal heave.
So there's no personal heave, no loud P2 also is not there. Only murmur is there, you said that also.
Yeah, murmur is there. Loud P2, I'm not appreciated. Matlab, able to appreciate is
Okay.
loud P2 or not.
Okay. Okay. So then based on that, we cannot say, no, PH, you said PH is present. So there should be some evidence to say that in your diagnosis, no, PH.
On the basis of ejection systolic murmur in pulmonary area, can we say so?
Okay. Like only that could not be, it could be some functional also, no? So we cannot say that. It was not very high grade, no? Which grade you
Okay.
said? That one. Grade 2, grade
Grade 2, sir, I said.
grade 2. No. So that's very unlikely to say that could be PAH. Okay. So generally, what happens now, if you are mentioning PAH as a diagnosis, you should your all the different other criteria should also fit in into that. That is loud P2, because that you may not be able to appreciate. Maybe sometimes we may miss that finding as such. But now, when you're mentioning PH, try to mention all those findings as well. So, like your clinical
Okay, sir.
examination and your final diagnosis should sync properly. So, even if it may not be there
So
also,
in that case,
but if you know that it's a PH, you have to
y-
mention that. That's it. There should not be mismatch
okay,
in your
sir. So in
this
that case,
examination
should I
findings and your final
mention
diagnosis.
narrow split also? Hello. Sir, should I mention narrow
In
split
that case,
also in that case? Because split I'm not able to audible.
uh, uh, so okay, so depends upon that. You didn't mention the severe
I think
PH was not
examiner will
mentioned. No?
think
Okay.
this is
You
too
just
much
mentioned
like,
pulmonary.
yeah.
Okay. So you just mentioned
Yeah.
pulmonary artery hypertension with features of that. Okay. Okay.
Okay.
So usually, if you know that it's a severe PH, na, so generally you should mention all the narrow split A2 P2 that should be there. Your loud P2 should be there, and parasternal heave also should be there. So suppose you are not finding
Yes,
any of
sir.
these features, then better not to mention in your final diagnosis that PH is there. Okay.
Yes,
Only
sir.
on ESM, I don't think it's right to say that. Okay. Okay. So
Yes, sir.
that's
Agree.
one. What are the other features of pulmonary artery hypertension? Like examination, what all features we will see in pulmonary hypertension?
In sound, S2 sound will be loud, narrow split of S2 on the pulse, blood pressure on the lower side, systolic blood pressure as well as diastolic blood pressure. Then on the inspection, the apex pulse is the diffuse down and out on the down and out from its natural position from apical. Then parasternal heave can be present in the murmur, ejection systolic murmur over the pulmonary area can be present, and a feature of the right-sided heart failure like pedal edema, abdominal distension, congestive hepatopathy can be hepatomegaly can be present. Sir.
Okay. And you said this patient has PND, na? Paroxysmal. So can you
Yes, sir.
say all the
After for
series
1 month,
beyond
and
PND?
after that, sorry, sir.
After that, you said it disappeared, na? You said something like that.
Yes, sir. After 1 month, it has disappeared.
Okay. So like how did that happen? He taken some treatment also.
Sir, might be the progression of the valvular heart disease, which causes the right ventricular non-compliance, and for getting a PND, we need a compliant right ventricle. So might be just the progression of the
Okay.
valvular disease, and the another differential definitely treatment, but there is no history of any treatment taken outside. So most probably the
Okay.
valvular disease natural progression is responsible in this case, sir.
Okay. And based on this, like MR or AR, which one you think it's the dominant one in this case?
Uh,
Based on your history and examination wise, what do you feel? Which one is more dominant, AR or MR?
Aortic regurgitation.
Irrigation. Okay. So, and why do you think that?
Because the left ventricular failure feature is also there, and the patient is having a severe AR feature like the wide pulse pressure, Hill sign positive.
Okay. Yeah. So Hillsign is actually more in favor of that, and also wide pulse pressure as such. Okay. And do usually does this happen? Aortic regurgitation progressing so fast before 6 months? No history was there.
Until and unless there is a atrial fibrillation, new onset rheumatic fever, or infective endocarditis, generally it's progressed slowly. But once it started, then the rapid deteriorating course is there.
Yeah. Exactly. Usually, at least some symptoms should have been there because starting at 6 months back and
Yes,
going so
sir.
bad, no?
He is
Like
a
coming to
retired
dyspnea in
teacher,
three
and
months to 12.
yes, sir.
Okay. Actually, he was not very mobile. You said.
Not very mobile, sir.
Oh. Hmm. So usually that was thing. So the short history, na, usually does not fit into this regurgitation lesions also. Like maybe if it is acute, suppose infective endocarditis or something like that, then definitely very acute worsening can happen. But usually the patient was so stable. Now suddenly in 6 months it has happened. So what are the precipitating factors for any valvular disease? Like stable valvular heart disease, why does it
Uh,
get worsened so fast? What do you think? What are the causes of that?
Ischemic heart disease, severe hypertension,
Okay.
infective endocarditis, new onset rheumatic fever, atrial fibrillation, any infection like pneumonia or any other infection, anemia, high output cardiac failure condition like anemia, beriberi, thyrotoxicosis. These are some common features which precipitate the heart
Okay.
failure, sir.
Okay. Okay. Mm, okay. So you have this ECGs or anything? And one more thing. What are the other causes of collapsing pulse? You said collapsing pulse, no?
Yes, sir.
What are the other
So
causes of
in
collapsing pulse other than AR?
any hyperdynamic circulation can cause the collapsing pulse like anemia, beriberi, thyrotoxicosis, cirrhosis of liver. In a congenital heart disease, patent ductus arteriosus can cause the collapsing pulse. And AS with AR, sorry, AR with AS with AR, sir, I think can cause. Not sure
Yes.
about valvular.
Okay.
AR can cause.
You know the mechanism of this collapsing pulse? How does it occurs?
Sir, when the initially the left ventricular eject a high volume of blood, so it
Mhm.
causes the high systolic blood pressure, and after that, due to that high volume of blood, there is a activation of the baroreceptor, and due to regurgitant
Okay.
lesion, there is a rapid runoff and the peripheral vasodilatation. So it causes the drastically downgoing of diastolic blood pressure. So there is wide pulse pressure.
Okay. Nice. Where did you read this? You read it from
From Kundu, sir.
Akundu only. Okay. Okay. Yeah, so few of the pathophysiologists you can read from here also. Somaraju is also very good in all mentioning all this pulse and all, no?
Okay,
You've read
Soma
that
Raju.
Somaraju book? Somaraju.
No, sir, I have not heard about.
Okay, okay. No, it's very good book. Like
Okay,
he
sir.
gave everything,
Will check,
like
sir.
all
Yes.
symptomatology, basically examination and this wise only. It mentions history and examination wise. So each part it gives, like pulse, each type of pulse, why it occurs, pathophysiology is all very good in it. Okay. I'll share the PDF with you. You can refer that. It's a very good book for examination and history taking also.
Yes, sir. Thank you, sir.
Yeah. And one more thing I want to ask. You have this ECG X-ray of this patient anything?
No, sir, I have not collected.
Okay, okay, okay. So that also would have been good. Okay. So otherwise, what do you think in this patient? Suppose just leave off MR. What do you think this patient ECG will be? How it will be? What all changes do you expect in a patient of severe AR ECG changes?
Uh, Left ventricular, biventricular hypertrophy might be. And yes, sir,
Okay,
biventricular
biventricular.
hypertrophy.
Why biventricular?
Because Patient is having a severe AR which can cause the left ventricular hypertrophy, and MR will cause the right ventricular hypertrophy.
Okay. But MR to cause right ventricular hypertrophy also, it is in end stage only. No? Usually, if your pulmonary
Yes,
is compliant, it may not be much RVH may not be there actually.
yes, sir. Agree,
Should
sir.
that also initially got LVH only, no?
Yes, sir.
Okay. Okay. So how do you describe ECG stepwise?
This is a 12 lead ECG with a standardization done, and it is showing a regular rhythm with a left axis deviation, and ECG is showing a left ventricular hypertrophy, and there is no STT segment changes.
Okay. So how do you say standard ECG? In ECG, how do we say that? What is the standard
There is
ECG basically?
at taper speed is 25 millimeter per second, I think. I'm not sure,
Yes.
sir.
Yes. Yeah, correct. Correct. If I remember.
Correct. Yes.
Anything else? One more thing should be there. In standard ECG, two things are there. One is speed and other is voltage.
Not sure, sir. Not remember, sir.
So normally it should be 25 millimeters per second, the speed, and the second thing should be 1 millimeter should be 10 millivolt. Sorry, 1 millivolt is equal to 10 millimeters.
Yes. Oh, okay, sir.
1 millivolt is equal to 10 millimeters. So these two things
Yes.
you should check in an ECG before starting the interpretation as such. Okay. So many
Yes,
times
sir.
in my exam also they may give you an ECG to interpret. So make sure you see these two findings before, because sometimes just to confuse you, they sometimes give you the normal standardized ECGs as such. And also in ECG there will be a bar at the last. No, in ECG you may have seen a
Yes, sir.
bar.
Bar.
Bar will be
Yes,
there.
sir.
Yeah, that bar should consist of 10 millimeters. That is 10 small squares should be there. Then also we can
Yes.
label it as standard ECG actually.
Okay, sir.
Okay. So ECG. So whenever interpreting any ECG, na, go this wise only. Okay. So now we
Yes,
do not
sir.
have, but always remember that in your exam, whenever they ask you, no, don't rush into diagnosis directly. Go stepwise only, no matter which ECG they give. Okay. So
Okay, sir.
standard rate, rhythm, axis, and axis is very important. Okay. So they tend to ask axis a lot.
Okay, sir.
So next, so okay, ECG will expect a LVH. Okay, so left atrial may be present, and RVH based on how much the pulmonary hypertension is there and how much the RV forces are there. That changes also we can see RVH also. Okay,
Yes, sir.
so can we see left atrial enlargement in this case?
Sir, less likely because parasternal heave was negative. So in left atrial enlargement, I should get a parasternal heave.
Okay. Oh, yeah, that in that case, even for right ventricular hypertrophy, you should get the parasternal.
Yes, sir. Yes, sir.
But in this case, patient is obese. Obese, you said? How much? It's 24, you said, na
Uh,
BMI.
24.2.
Okay. So that may be missed actually. No, but usually if that is AR or MR, anything is there. So first, if if your left ventricle is getting enlarged and LA also should get very much enlarged, then only actually the pulmonary hypertension and everything will develop. Because if your LA is compliant, no, usually it does not lead to PAH as such so early.
Okay. Okay, sir.
So even left ventricle enlargement will be definitely will be there. If you have a PH, I'm supposing this case have a PH, so then definitely your left ventricle should also be enlarged.
Yes, sir. I might
So
have missed that finding, sir.
yeah, yeah, so that's fine. Okay. And what are the ECG changes you expect in a case of left atrial enlargement?
Uh, in left atrial enlargement, P mitral I can see, and the atrial fibrillation.
Okay. Other than that, another thing, you know what is Morris index? You're aware of it?
Mm, yes, I heard, but I don't remember.
Okay. So write
Okay.
somewhere, no? You can see that. Okay.
Yeah.
Two things are important in left atrial: Morris index and one is Macruz index. So I'll text it in the chat maybe somewhere here.
Okay.
So one
So
is
is it
Morris
to
index, second is
differentiate
macros index.
right and right atrial and left atrial enlargement differentiation is done by Morris index or what?
No, no, it doesn't differentiate between right and left, but the okay. So it's actually they see the ratio of macros index is I think the ratio of the P wave duration with the PR segment duration. So based on that, if they give if the value of P wave and PR. So suppose if there is left atrial enlargement, what will happen is the P wave duration will increase, no? P mitral as
Yes.
such. So P by PR ratio will increase. So if it is more than 1.6, I think the mentioning is 1.6. If it is more than 1.6, it is labeled as left atrial enlargement.
Okay, sir. Thank you, sir.
And similarly, Morris index. No, these are some fancy questions of the examiners. Morris index and macros index.
Okay. Thank you, sir.
Macros, that is MACRUZ, macros index. You can see that also. Okay, so that. You said AR, no? So what are the changes you'll expect in case of like chest X-ray? As I'm saying, what are the changes you'll see in case of aortic regurgitation in chest X-ray? What all findings do you expect?
Uh, Left ventricular hypertrophy. So cardiomegaly we can see, and if it is associated with pulmonary edema, then curly B line can be seen, or the pulmonary edema we can see on chest X-ray, sir.
Okay, left ventricular hypertrophy and that. Okay. So in X-ray, how do we say whether it is left ventricular hypertrophy or right ventricular hypertrophy?
Uh, if right-sided paras on the X-ray, we draw.
On the X-ray, I'm saying, on the X-ray.
I'm not sure, sir.
Okay. So you're not aware of this cardiophrenic angle we have to see, no? So
Okay,
left
no,
side
I'm not aware of
cardiophrenic
that.
angle. Okay. See that. So basically, we have to see the cardiophrenic angle. So left ventricle apex angle and the diaphragm. So we will make a angle
Uh,
vector on that. And if the angle is acute angle, then it is said to be right ventricular hypertrophy. And it is if it is obtuse, it is more than 90 degrees, then it is left ventricular hypertrophy.
okay, sir.
Okay. And also when reading external, you see this also. What are the sign changes of pulmonary venous hypertension
Pulmonary
in
venous.
X-ray? What all will see? You aware of what all you will see in X-ray in case of pulmonary venous hypertension?
Descending pulmonary artery diameter will be increased on the X-ray, and
That is pulmonary artery, no? I'm saying venous hypertension, not arterial hypertension.
okay. No, sir, I'm not aware. I will see, sir.
Okay. Yeah, yeah, see that also. I'll share a PPT. I have a PPT of chest X-ray. You can read that.
Oh, okay.
So
Thank you, sir.
it has
Yes, sir.
okay. So chest X-ray. These all are important because then this comes to like basic only. You should not get stuck at this basics of X-rays and all. Okay. Okay.
Yes,
And
sir.
left atrial enlargement. Can you say in X-ray whether left atrial enlargement is there or not?
Uh, hmm,
Yes, sir.
don't.
Anybody else can also answer. Not an issue. Only Darbin may not answer.
Left atrial enlargement, there will be straightening of the heart, left heart
Okay,
valve,
and
that is
and there
one
will
thing. Okay.
be
double
bi
atrial
bilateral.
shadow.
One is double lateral shadow. Yeah, very good. So there are four features usually. One is they say is the widening of the carina. So that is uh, the angle of the bifurcation of the trachea will be there. No? So trachea bifurcating into the both the bronchi, the angle that will increase because this left atrium enlargement usually push the left bronchus, origin of the left bronchus slightly upwards. So angle of that will increase, and also there will be elevation of the left bronchus as such. And the double atrial shadow is one, and straightening of left heart border, as you all rightly mentioned that. Okay, okay. So no problem. All I mean, and whoever exam going are there, na, just read all these things. Okay, okay. So each chamber enlargement is important. Like what are the X-ray changes you will see in each chamber
Yes.
enlargement? Basically, left atrial, left ventricular, right ventricular enlargement. How do you say? pulmonary venous hypertension, and based on X-ray also we can say how much pulmonary venous hypertension is there. Also, grade of PVH also we can say actually.
Okay, sir. I will read
Okay,
up,
so
sir.
all those are things. Yeah, I'll share you that. I have an PPT also on that. I'll share with you all. You can go with that also. Okay.
Okay,
Okay.
thank you, sir.
So
Yes.
next, what is the next investigation you would like to do?
So I will do
ECG is
first
done, X-rays, then what else?
routine examination. First, we'll
Hmm.
start with routine examination, complete blood cell count, renal profile, electrolyte, and liver profile test. And after that, ECG, 2D echo. I
Hmm.
will like to do, sir, 2D echo next.
Okay. So what information do you want to gather from 2D echo in this case, specifically to your case?
In this case, regurgitant lesion velocity of aortic regurgitation and mitral regurgitation, and if there is any pulmonary hypertension is there or not.
Okay.
And
So
IVC diameter,
you
sir,
know the
which is
criteria of echo? Echo criteria, how do you say severe AR based on the echocardiography?
sir, if the left ventricular diameter is 50, uh, more than 50, then it is a severe AR, I think, which needs to be operated. And the left
Yeah,
ventricular
you're
ejection
saying about
fraction is less than
operate
50%.
surgery. Okay. No, that is the indications for surgery you are saying. But I'm saying, how do you in echo, what do
Uh,
you see to label it as severe AR? How do you do that? What all parameters you should see to label any patient as severe AR?
uh, I don't know, sir. Hello? I don't know, sir.
Okay. Yeah. Okay. So that is important. You have to see few things are there. No, one is you are aware of this jet width in parasternal long axis view. We see the width of the jet, the aortic regurgitation jet, the diameter of that, and the left ventricular outflow tract diameter ratio is there. Okay, otherwise just
Okay,
write
sir.
down. No? This question is important. There are 6, 7 things are there. Okay, sometimes see if
Yes,
many
sir.
of the places
So,
they may give you direct echo machine directly to demonstrate the findings as such. So before demonstrating, you
sir,
should be aware
actually,
of
we are
what
in
exactly you need to
medicine.
see.
Actually, we are in medicine, so
Oh,
we
okay.
even don't know
Yeah,
how to do echo.
yeah.
So,
Okay, fine, fine. But still, some basics, maybe I think
uh,
you can read about
So
at least.
regurgitant volume
yes,
and
sir.
regurgitant fraction, I think, are
Uh,
features.
Okay. There are 7 things actually. Okay, so one is the jet width by LVOT diameter ratio, and okay, whatsoever. I mean, you can just see the names actually, because sometimes some people expect that even if you are like general medicine also, you should be aware of some basic of
Okay.
echocardiography basically. So even if you don't know the full details of that, so just the names of the parameters. Okay, so what are things are there?
Okay,
4 or 5 things you can just remember. So this will just add on to your points basically, nothing else. Okay, but X-ray is definitely you should remember. All
yes,
these chambers and all is not an exception. Even if you're medicine also, that's not an exception for that. Okay, so you do echo and
yes,
okay,
sir.
so that's fine.
Mm.
So how do you manage this patient?
Is this patient is having symptoms, and on the basis of the echocardiography, first we'll say this patient need a cardiac intervention or not. If the patient is already symptomatic, so this patient will require more probably cardiac intervention, aortic valve replacement, or and mitral valve replacement, sir. And otherwise,
Okay,
we'll try to control the hypertension of patient to decrease the regurgitant jet.
okay. So routinely, suppose this patient was asymptomatic, and routinely a patient has come with your echo findings that is there, and you have seen a murmur is there. So then, what are the all indications for surgery?
If the left ventricular ejection fraction is less than 50%, if
Okay.
left ventricular end diastolic diameter is more than 50, and on exercise stress test if there is a hypotension, I think, sir. Not sure
Okay.
about other things, sir.
So that is no issue. So one is the EF less than 50, which you've mentioned at least. Suppose the patient is asymptomatic and EF is less than 50, it's an indication for surgery. Second thing is you said no, that is not end systolic, like end diastolic, not that it is end systolic dimension. End systolic dimension, if it is more than 50, or end diastolic dimension should be more than 65.
Okay, sir. Yes, sir.
End diastolic should be 65, and end systolic should be 50. Okay.
Okay, sir.
So if that more than that is there, then it's an indication is there. Or suppose asymptomatic patient undergoing any other surgeries. So suppose patient is going for bypass surgery also. Then if a patient is having severe AR, then also it's an indication for aortic valve replacement as such. Okay.
Yes, sir.
So which suppose so you're planning for a surgery, which valve will you prefer? So what are all the valves you are aware of? No, what all valve we can use for surgery?
I have read in past, but not remember, sir. Like
Okay.
metallic valve, bioprosthetic valve. There are two type of valves.
Correct. Yeah. So in this patient, which one will you prefer?
So as this patient is having age of the 60 years, so I will prefer a metallic valve, sir.
Metallic valve. Okay. So then you know the criteria at what age generally we should prefer for mechanical metallic valve and what age for bioprosthetic valve.
Uh, no, sir. I think, sorry, sir. I think old age is for the bioprosthetic valve and the young age is for the metallic valves.
Hmm.
Age cutoff,
But
I don't know, sir.
yeah. Okay. So usually the age cutoff is usually they say is see suppose the so age group is how they distribute is less than 65, less than 50 is there. One is less than 50 where you have to go for mechanical valve only, like this metallic valve, less than 50. 50 to 65 is a borderline zone. It depends upon patient to patient and clinician. You can decide based on that. You can either choose bioprosthetic or mechanical. You can give options to the patient itself, both of them. More than 65, usually
Yes.
they say is bioprosthetic valves are generally preferred. Okay. So they ask that, okay, for medicine level also,
Yes.
they ask this, and also mechanical valves types also, the names you should know. What are you are aware of the valves? Mechanical valve, which valve they
Uh,
use? You are aware of that?
n- no, sir. I'm not aware, sir. I will
Oh,
read up, sir.
okay. Read that. There are, one is St. Jude's valve is there. Star Edwards valve will be one,
Okay.
and there are three valves which you should remember in that. Okay, so many of time they ask that in for medicine people also the name of the valves is there.
Okay. Yes, sir.
And what precaution? Suppose so this patient's come into 60, so it's borderline actually. So he can choose any of them. So suppose this patient is going for mechanical valve. What will be your like post valve recommendations on treatment? What will you give him?
So the patient is on the
Any treatment is
mechanical
required or
valve.
not
We
required?
need to start on the anticoagulation. We need to give for the lifelong, sir. So we will start with
Okay.
warfarin. First, we bridge with a injection of enoxaparin, and after that, we'll bridge with the warfarin, sir.
Okay. So, and what will be your this INR criteria for that?
So we'll maintain INR
Like how
of
much will be your
2
target
to
INR?
2.5 in the sir, 2 to 2.5 for the
Okay.
metallic wall and 1.5 to 2 for the bioprosthetic wall.
Okay. No, so that's not that. So normally for metallic, sorry, mitral valve, for mitral valve replacement, suppose metallic valve is there, the target is 2.5 to 3.5.
Okay.
Okay. So, for aortic valve replacement, metallic valve if it is there, then target is 2 to 3. For bioprosthetic
sir.
valves, usually you need anticoagulation only for 3 to 6 months. After that, anticoagulation is not required.
Yes, sir.
Okay, because it's
And sir,
natural
during
only.
this
No?
three
Natural
to
valve
six
usually
months,
does not require
any target
anticoagulation.
INR? Yes, sir.
Target
But
INR
during
is
sir
again
this
same, 2
3 to 6
to 3
months,
only.
we same. Okay,
Same,
sir.
same target only. But usually 3 to 6 months only.
Yes,
After
sir.
that, it's not required.
Okay,
So
sir.
that is the difference, na, bioprosthetic versus mechanical. Main advantage is that it prevent you from this anticoagulation and all, bioprosthetic valve. But usually the durability is usually 12 to 15
Yes, sir.
years only, the durability of the bioprosthetic valves is such. Okay. Any dietary advice you would like to give to
Yes,
this
sir.
patient post-surgery? Yeah. Yeah. What will you advise?
Uh, uh, to decrease salt intake less than 5 gram, and
Okay. Other than that,
Green
decrease
leafy vegetables. Green leafy
le-
yeah.
and maintain same diet chart for means did not excessively eat a green leafy vegetable on one day and suddenly stop. So you should maintain a diet plan properly rather than changing in the diet habit day to day. It will
Okay. So
help us
basically
to
two things.
monitor
One is
INR.
correct. One is vitamin, since you cannot give green leafy vegetables contains this vitamin K. So you are using vitamin K antagonist. So there are two ways by which you can follow it. One is to completely avoid the green leafy vegetables. Then is that is the one. Suppose in our Indian settings that may not be possible for many of the poor patients who cannot do that. So then if they want to take green leafy vegetables, you have to say that same quantity of green leafy vegetables they should take daily.
Yes, sir.
Okay, so two things. So usually all the books and all everything says that you avoid green leafy vegetables, but generally in some of the Indian settings they say that if suppose somebody wants to eat, they have to take the same quantity daily. Then we know that no, so fixed amount of vitamin K they are taking, so
Yes,
we can
sir.
adjust the dose based on that. So that's a possibility. Another thing you said
Yes,
is a
sir.
salt restriction that will be there only if a patient have ejection fraction is less. Then only we advise salt restriction. And how do you tell patient 5 grams? So they cannot measure 5 grams, no? So how do you advise them 5 grams
Uh,
of salt?
to take less than 1 teaspoon of salt in a day.
Correct. Yeah. So you have to say that 1 teaspoon is usually 5 grams. Okay. So that is the thing. Okay. I took so suppose this patient was age of 30 years of age.
Yes, sir.
So what all other
Hmm.
than this, what all treatment will be there in that patient? Other than what we spoke, no? Any other thing will you add in those patients?
Uh, I don't
So
know, sir.
basically, I'm asking about the prophylaxis. You're saying rheumatic heart disease, no? So prophylaxis, I'm asking about.
Oh, okay. For the rheumatic heart disease prophylaxis, every 21 day, 1.2 million benzathine penicillin injection patient should take. If the patient is having a
Okay.
rheumatic heart disease, like in this case, for the lifelong, according to WHO classification and according to the ESC, 40 up to the 40 years, patient should take, or the 10 years, whichever is the longer duration.
Okay. So, alternate for Penidura. Suppose there is an allergy to benzathine penicillin. What all you will give?
Uh, azithromycin can be given, sir, and
Okay. Dosage, the
azithromycin, sir,
dose.
we can give.
Hmm.
500
Like
mg
dose I'm
OD, sir.
asking. Okay. How long?
500 mg OD, sir.
Like how long? Same duration?
Uh, sir, not sure. Every day, 500 mg OD, sir.
Yeah. Okay. Yeah, that's second. 500 mg OD every day only. But read this also. Okay. So all this prophylaxis drugs, na, uh, what all drugs should be
Yes.
given? What are the like dosages of them? and how much duration should be given. Okay, for criteria wise, there are two
Yes, sir.
things. One is WHO guidelines is different and the American Heart Association guidelines is different. For WHO, usually
Yes, sir.
guidelines usually says that for these patients, no, or suppose the patient is undergoing mitral valve replacement or aortic valve replacement, they should uh, take therapy for lifelong. Actually, this prophylaxis therapy.
Okay. Okay, sir. Yes, sir.
So any cardiac case, valvular heart disease, just remember this. You should read the prophylaxis part. Uh, Infective endocarditis also very clearly also. Okay, and other than that, what is yeah, I think that should be enough. I think. Any other doubts you have in this?
No, sir. So I just have if
Okay. Anybody else?
patient is having mitral regurgitation,
Hmm.
sir, this patient is having mitral regurgitation. If pulmonary hypertension is still there, so in that case, the pulmonary hypertension causes narrow split, and mitral regurgitation causes wide
Okay.
split. So we are definitely not able to hear any split. So in that case, what should we write?
Okay. In this case, then if you hear anything, you write.
Definitely in
Otherwise,
this case.
you can just mention it as okay. Now, suppose you are mentioning pulmonary hypertension, na?
Ha.
Usually not this much. Usually that much split sometimes is not very much evident also. So many of the examiners also do not object much if you do not ask mention about the split as such. But if you're mentioning PAH, na, usually they expect you to mention the parasternal heave and loud P2. That should be there. If both of that is not there or you
Okay,
are not
sir.
recognizing that, then better not to say pulmonary artery hypertension. Because
Yes,
then
sir.
you get stuck.
Okay, sir.
What they feel is you must be knowing the diagnosis. Somebody should have said you the diagnosis and all. So you're biased. So that way, the discussion can go in that way. So if you're mentioning anything,
Right,
you
sir.
should be aware of all those things. And also read this severity of how do you grade severity of murmur? No, I'm saying MR severity. How do you say clinically? I'm saying. So what you mentioned, pH and all those, these are all
Oh,
secondary criteria, but those are not the main criteria. Actually. The loudness of murmur matters, the duration. So everything's are there. So for each murmur, you read this.
duration of
Okay,
murmur.
MS,
Yes, sir.
AS, MR. Yeah. So MS
Yes,
murmur,
sir.
you should read all the four murmurs. Na? MS, AS, MR, AR. How do you say severity of all these things clinically? That you write down somewhere, and you have to be like, if somebody asks you, you should be very rapid. You should answer all those things. Similarly, what are the features of pulmonary hypertension? In clinically wise, what all will be there? So that all should be aware of. Okay, so that you should
Yes, sir.
mention.
Okay, sir.
And this treatment part you said, okay, we have discussed about treatment. ECG and they may not ask you ECG, but X-ray they can ask you, I think.
Yes,
And
sir.
you should
Yes,
be
sir.
aware of some spotters will be there. No? Definitely they can give you some X-ray and ask what it is there. No? So you should
Ha.
be aware of X-ray and
Different table
ECG.
is there.
Basic ECG and echo, I don't think they may ask, but few of the examiners usually like to know that you know something about the echo. They may not ask you the exact values as such. Okay, what will be the this much values of each thing, but what all you will see in AR, MS, what all you will see. So some basics of echo you should be aware of that also. Okay, and examination wise
Okay,
is
sir.
fine.
Yes.
Then in value hard disk also read about all the rheumatic fever, completely about rheumatic fever. Okay, the Jones
Yes,
criteria
sir.
modify. Okay, that you should read about. And infective endocarditis, similarly modified Duke's criteria and all. Some people are very fond of asking that also. So suddenly, you must have read for theory
Yes.
and practical. Suddenly, if you don't read, suddenly they may ask you everything to tell about Jones criteria, and you should not think that time. So all these things are these are the basics things actually. So this should
Yes.
when they ask you, you should not get stuck here. Okay.
Yes, sir.
Another thing is your history should be very fluent. You have speech like presented very well, but since you are reading it, without reading also it should be fluent.
Yes, sir.
And also while presenting case presentation, try not to give gaps. Go slow. It should be slow. Definitely, it should not be very fast. Go slow, but do not give gap. Like suppose you have said there is no history of family history, so don't give a gap here. Next, go to the next heading simultaneously. Don't give time to examiner to ask you more questions. If you're giving gap, they'll ask more questions, and they'll be thinking that you are not
Yes,
very
sir.
sure about it. That's why you have given a gap. So don't give a gap. So if you finish your history,
Yes, sir.
like usually what they say, na, if you finish your history and examination without much stoppage, no, you have passed the exam. Okay.
Okay,
So
right, sir.
treatment part, all this treatment discussion, X-ray, all these things are bonus points. Like these are only for your extra marks. Okay. So if you stuck
Yes,
in
sir.
history and examination, na, then that means there is really something wrong. So try to skip that as fast as possible. Like it should be steady, slow reading, but don't give much gaps. So gaps also they think that you are not very confident about the case. So that also brings that. Okay.
Yes, sir. Yes, sir.
And then don't get biased by what you see in your like. Suppose somebody tells you the diagnosis also, no, don't get biased by that. Okay. So basically,
Okay.
they
Yes,
are
sir.
nobody is very interested ki you are finding the right diagnosis or not. Maybe everybody is interested in knowing how you are approaching to the case, how your approach is,
Yes,
like
sir.
how you are taking the history. So based on history, are you approaching to the right diagnosis or not? Okay. And similarly,
Hmm.
examination also, you are going in a proper way or not. So sometimes what happens, many of the people know the diagnosis, and even if there is funding is not there, they try to say that. So then they get stuck up there.
Hmm.
Okay. So go into an approach, even
Right.
if your
Yes, sir.
funding may get some mismatch will be there, but if your approach is right and if you're genuine, they'll not fail you. They'll generally pass you in that.
Yes, sir.
Okay. Okay. So congenital heart disease, now
Okay, sir.
basically you just read about only the basic AHD, VHD, PDA, and TOF. These
Okay.
four basics of that should be aware of. I said in terms of, I
Yes,
think
sir.
DM, I was thinking it was a DM case presentation, so that may be there. But only these four you should be aware of. Sometimes VSD they can give you as a case presentation also in exam for DNB people. No?
Yes, sir. Okay, sir.
Okay. Okay. I
Okay.
think we
Thank you,
can
sir.
end here
Yes.
now. Okay. Yeah. Any other doubts anybody else can
Thank you,
have?
sir.
We can ask. No? Yeah. Okay then. If you have
Mm,
any other
Thank you, sir.
cases, na, let
yeah.
me know
Thank you,
prior.
sir.
We can do more case
Uh,
presentation. If it's there.
yes, sir. Yes, sir.
Okay, next
Sure,
time
sir.
try to
Thank
get
you, sir.
X-ray if possible. If you have X-rays and all, try to get it also. That will be good.
Okay, sir. Will do, sir.
Okay.
Okay. Thank you, sir.
Thank you,
Okay.
sir.
Thank you, sir.
Hello.